Good afternoon, everybody, and I'm going to call the meeting of the Strategic Initiatives and Planning Committee to order. Can we please confirm that we have a quorum?
We do.
Thank you very much. So the committee is expected to adjourn at approximately 2 o'clock, and the live stream of this meeting is available to the public on youtube.com at the ABOR Live link. As you heard this morning, the board has been deeply engaged in current events at the University of Arizona. But we have also had the responsibility to continue to move matters of day-to-day governance forward with all three of our universities. Before we turn to our discussion today of the Healthy Tomorrow's opportunities, I wanted to approve the minutes from our prior meeting. So are there any questions or comments related to the minutes? Seeing none, I'm going to move that the committee approve the public session minutes from the November 2nd, 2023 Strategic Initiatives and Planning Committee meeting. Is there a second?
Second.
All in favor?
Aye.
Aye.
Any opposed? Motion does carry. So the Governance and Operations Committee for approval of the ASU medical, sorry, I skipped a page. Today I am very excited for this committee to receive an update on the Arizona Healthy Tomorrows program, our new initiative to address critical workforce shortages among physicians, nurses, and other healthcare professionals in Arizona. Leveraging the combined resources and expertise of ASU, NAU, and the University of Arizona, we are increasing the numbers of doctors, nurses, physicians assistants, physical therapists, and more. We've provided Regents with handouts of a graphic that provides a timeline of Arizona Healthy Tomorrow and the scope of what this bold plan includes. We'll make this available on our website as well. It provides a helpful, at-a-glance reminder of our goals with this initiative. I'd like to express the committee's appreciation to Governor Hobbs for her investment in the program and for her strong endorsement of the initiative in her State of the State address and executive budget. Producing more doctors for our state is central to Arizona Healthy Tomorrow. Last year, the board announced 2 new medical schools which will be created at ASU and NAU. Launching a medical school is not a small undertaking, and we are eager to hear about the progress. The board has engaged 2 healthcare executives who are collaborating with the board and the universities to grow the MD workforce in Arizona. I'd like to introduce Dr. Jackie Chadwick, a family practice physician with more than 40 years of practice in Scottsdale. She has previously served as Vice Dean of Academic Affairs for the University of Arizona College of Medicine, Phoenix, and the Burnett School of Medicine at Texas Christian University. Ms. Judy Burness is currently the Senior Associate Dean of Strategy and Communication at the Burnett School of Medicine and has previously served as Associate Vice President of Communications and Government Affairs at the University of Arizona. Thank you for both of you for being here today. We appreciate your collaboration with the universities on our healthcare initiatives and are eager to hear your update today. So at this point, I'm going to turn the floor over to Dr. Chadwick and Ms. Burness.
Great. Thank you so much, and thank you all for having us here. We're excited to be a part of this program, and Jackie and I have worked together for many, many years, but we're excited about this Arizona Healthy Tomorrow. It's something that really brings up to us a lot of the important things about making sure that there's access for Arizona citizens to health, and really all the things that we have done together to really help make this happen. I put on my intro that I'm incoming chair of the Fiestable board just because I am here all the time, and I also want to, while I'm here, make sure that you all know that we have the first quarterfinal coming up this year. So. Let's see. All right, so I don't need to tell you what the Arizona Healthy Tomorrow goals are, but the reason that we're here is because we're talking about the workforce, right? The Regents have done a great study about the workforce in Arizona and healthcare, and that informed a lot of what we're going to talk about today. But clearly, we know that we have shortages in Arizona of healthcare professionals, not only physicians, but throughout the whole gamut of healthcare workers. And let me say that we, in the time that we've been on board, which is really only about 3 weeks, so we've had the opportunity to speak with the leaders from Arizona State University, Northern Arizona University, and University of Arizona, talk a little bit about what the plans are to expand these medical schools and create new ones. And also we've had the opportunity, there's another new program that's being proposed. It's the ValleyCom, which is another osteopathic school. There are currently 2 osteopathic schools in Arizona. This would be a 3rd. So we've had the opportunity to talk to them a little bit about what their plans are as well. All of these programs going forward are kind of really focusing on Arizona residents. They're looking at primary care, which is a huge need in our state and around the country, and also looking at rural and underserved areas as well. All right, and I'm going to pass it off to Dr. Jackman.
So you all know about the state of the workforce in Arizona, and we're really focusing primarily on medical education. That is our background and our expertise. So currently, if you read the slide, you see that we already have 2 medical schools with University of Arizona. There are also 2 private medical schools, Mayo and Creighton, and there are 2 osteopathic schools, as Judy mentioned, A.T. Still, which is housed in Mesa, and Midwestern University in North Phoenix area. Right now, current state, the total number of medical students per class is 812 for those schools. If we roll up all of the future proposed medical schools to date, which includes doubling the class size for the University of Arizona's 2 medical schools, the ASU Medical School, the NAU Medical School, and the new osteopathic school, not taking into account any increase in the private school numbers, we're looking at an increase of almost 70%, up to about 12,000. Now that's incremental. It's important to know that's not a big jump from 812 to next year over 1,200. So it's going to take time to get to that point. There are a few assumptions in there because some of the schools have not determined what their total class size ultimately will be for the new schools. So it's an approximation. We put that in place because that's going to give context to some of the things that we will discuss with you a little bit later. So what we learned from the leaders at the 2 new proposed schools were that ASU would look at hopefully 2026. NAU, the earliest they said they could really do anything was 2028. The doubling of the class size at the University of Arizona's 2 schools, a modest increase is proposed for next year, but the doubling is going to take significantly longer. And the important thing to recognize is that resources are going to be necessary, really, to do this significant increase. The Valley College of Osteopathic Medicine, which is the new private investor model school, is proposing their inaugural class in 2026. So I thought it would be important to revisit the pathway to becoming a doctor because that will again give context to some of the challenges that schools are going to face in the future with this increase in class size. Obviously, pre-med has certain requirements to get into any medical school in the country. Usually, the schools require a 4-year degree of some sort. It can be in any major, but usually 4. Occasionally, there are fast track that can give 3 years of pre-med, but usually it's a 4-year, and then application to medical school. Medical schools are generally 4 years. There are several 3-year schools in the country. That model is becoming a little bit more interesting lately in order to turn out workforce, but most of them are 4 years, resulting in an MD or a DO degree. The important thing to remember is the difference between medical school, which is called undergraduate medical education, you'll often see UME, versus GME, which is graduate medical education, which is residency. So a student graduates from medical school with an MD or a DO degree, but they're not specialized in anything. They're what I used to call an undifferentiated doctor. So they have to then go on into residency to learn to be whatever it is they're going to be, family doctor, emergency medicine, surgeon, whatever. How they get into that residency is called a match, and that's a national organization that a computerized event takes place at exactly the same time every year in March for all of the fourth-year medical students, where the students go and interview at school at residency programs that they want to go into. The residency programs interview all of the student applicants that they might want to take into their residency. The program, residency program, puts a match list together, ranking the students that they've interviewed, 1 to whatever. The students rank which residency programs they want to go to, and then a computerized match occurs, giving the student the benefit of the doubt along the way. So they try to rank to the student's highest match request. Then the students, it's very competitive. Some specialties are more competitive than others, but then the students go into a residency program. They have their MD, they have their DO degree, but now they're learning how to become that specialty. Specialties can be 3 years for most primary care specialties, up to 7 years for a lot of the surgical subspecialties. Plastic surgery, neurosurgery are a lot longer. And then certain residents may want to go into fellowship where they get additional subspecialty training. So internal medicine, for example, they'll go 3 years of residency, and then they might do 1 to 2 years of fellowship in cardiology to be a board-certified cardiologist. The other thing to note here is that in medical school, the curriculum is generally 1 to 2 years of basic science education, just to get the foundation for understanding the science of medicine solid. But then the clinical training, which now fortunately occurs very early in medical school, usually from day 1. When I was a medical student, I didn't see a patient until my 3rd year of medical school, which is ridiculous. But now, fortunately, we get our students in with patients right away. But the core rotations in the clinical arena occur during what is called the clerkship year, where students rotate through all of the different major areas: internal medicine, pediatrics, surgery, OBGYN. They rotate through all of those. And it's frequently in that year that the student decides what they want to be when they grow up, what kind of a doctor they really want to be ultimately. The reason I bring this up is because that clerkship year, as you might guess, is crucial. And we place students traditionally in the hospital setting. We're doing a lot more now with outpatient training because medicine is practiced primarily in an outpatient arena right now. It's no longer all hospital. But the students have to learn in both a hospital setting and an outpatient setting. That's an LCME accreditation requirement for medical students, medical schools. So that clerkship training needs to be very robust. The students can't just be thrown onto a hospital ward and find their way around and figure out what it is they're supposed to do. It's very structured. And right now, with our 812 students in the state per year, in that core clerkship year, clinical training sites are not robust. We don't have vast numbers of extra clinical training sites. So we know that as we ramp up our numbers of medical students, we really need to ramp up our number of clerkship training spots for our students so that they're adequately prepared to then enter their residency. The second thing is with residency is we know that we don't have near enough residency slots in this state. So if we want to keep our students here, we're going to have to ramp up our residency numbers as well.
Right. So a couple of things as Jackie and I have begun talking to folks and looking at what's being put together. What are some of those important considerations that we need to continue looking at? And as we go along through this process, anytime we'd love to hear from all of you too about what some of those considerations are that you'd like us to delve into a little bit more. We want to look first at the number of GME slots compared to the number of student slots in the state. So right now, Arizona's ranked 28th for the number of medical students as opposed to the number of GME spots, which means we have more medical students than we do GME spots to put them into. And so that's something we want to look at as we go forward to make sure that we're providing opportunities for our students who graduate here to have the opportunity to go into residency. For an example, in Texas, where we worked on the TCU Medical School, the Texas Higher Education Coordinating Board required a new medical school to have a 1.1 new GME spot for every member in that of a class size you were starting. So if we were starting with 60 students, we needed 66 residency slots with our partners to create those. So there are some different ways that people are looking at how do we ensure that we have the right spots for our students. Then again, looking at the number of residents and fellows that we have in Arizona. So we're ranked 39th, which means we're in the bottom half of that. But that means that we could have room to grow, right? We need more residency spots here. We want to attract more students to come here to Arizona. And you may say, well, why is it hard to create more residency slots? And just a little trip down history lane, but in 1997, the federal government capped the number of residency spots, of federally funded residency spots. So they stopped funding new spots. And in 1997, our population here in Arizona was a lot different, right? We have grown a lot since then, but there has not been a huge growth of federally funded residency spots. There have been small increases in rural areas and in underserved areas, but not a large number. There are a few small exceptions to that. One, if it's a hospital that hasn't had any residency before, even a part-time resident, they could create some new residency spots that the federal government would fund. But there are very few of those hospitals that have not been touched by residency. Sure.
On the prior slide, in the bottom category, it says, and I'm a little blind, is that 19 to 75?
Yes, 19.2.
To 75?
Yeah.
Does that mean somebody has 75?
It's a good question. It's a good question.
Probably New York.
It is
I would
probably
think
New York or
New York
yeah.
City.
That would be what I.
And so what's happening, even like Michigan, if you looked at Michigan, right, their per capita residents per 100,000 population has gone way up because their population has dropped while their number of residencies has stayed there, where we have the exact opposite, right? In Texas, the same way, right? The population has grown so much, so.
Yeah, thank you.
But, well, can I just do a follow-up?
Absolutely.
I mean, growing population also means more members of Congress. So why aren't the growing states
Yeah.
using that new congressional leverage to
Yeah.
change the law?
Well, that is such a good question.
Assuming a functional Congress.
You are spot on. So since that cap was put in place in 1997, every year there have probably been 5+ bills introduced to fund new residency slots, but none of them have ever passed. There have been bills that have proposed new residency slots for new medical schools. None of those have passed. And part of the problem is when you think about what's happened, because so many hospitals have created new slots. When a hospital like Banner that we've worked with before, right, has created new spots on their own, they have to fund them on their own, right? A residency may cost $150,000 a year per resident, and if it's a 3-year residency, you've got to figure out that's $450,000 for that one resident. If you want to create a program with 50 residents, multiply that times 50, right? It's not inexpensive. So these hospitals have funded this because it's part of their future workforce. But when these bills have been introduced, and academic medical centers have joined together to help push these bills, but those hospitals like New York, where a bunch of the hospitals have paid for their own, they say, well, if you're going to fund new spots, first we want to be paid back for all those spots that we paid for on our own. So there's this, so it's now not just all of the new spots we want to add, it's paying for those that weren't paid for, plus the new ones. And so the number just gets gigantic. And so there's a solution out there, and at some point those hospitals are just going to have to give that up. But that's where the challenge kind of lies, where it gets stuck, where there's really a big consortium that wants to get those passed, and then other folks going in behind the door and changing their mind. And it's a lot of fun. So that's really where that has gotten stuck.
And it's harder and harder to find
sorry.
hospitals that haven't experienced having a resident, in their system training them. So once you have a resident come there, then you can then you're capped. So it's hard to find a hospital system. Some rural hospitals would fit that, but it's hard to find ones that haven't done some training.
Richard Herbal has a
Yeah,
question.
you're talking about hundreds of extras, right? Extra residency slots.
You mean, well, they aren't extra, so there aren't enough right now.
No, I mean, you're going to need them.
Oh, yes, we will need hundreds of them.
You described something that doesn't have a lot of hope to it.
Well, we're always full of hope. We're optimists. But I do think there are opportunities out there. Some of the bills in this last year or two have gotten much closer to getting passed. And I think we are getting to a dire situation. There were about 1,000 MDs who graduated last year who did not get matched. Now, there are still some residencies that didn't get filled, but they're in programs that either might not have been as strong or in fields that aren't as popular anymore. So there's a real lack of enough residency spots for all of the new medical students. Over the last decade, there have been a number of new medical schools that have come up to help meet the need, right? We're having a shortage of MDs throughout the country. So medical students have stepped up medical schools have stepped up to increase the number, but that number of residencies hasn't kept pace with the number of students.
So where do those 1,000 students go?
It's a tough one, but some of them will stay and do a research year. Some of them will do a master's degree. Some will end up going to work for an insurance company that you don't need to be board certified, but you have a medical license. So there are different things that people do, and many will try again and reapply to different programs.
But then you've just compounded the issue for the following year.
Bingo.
correct.
Yep.
That's correct.
Yep.
Sorry, thank you.
Oh, absolutely. All right, Jackie?
Okay. Yes, so our goal is to keep these graduates here. So if you look at the statistics from the AAMC, you can see, and I've circled Arizona's statistics. If you're looking at those students who go to a medical school in Arizona, about half will then stay in Arizona afterwards. The second table is for residents. If you do your residency only, not your medical school elsewhere, your residency in Arizona, about half end up staying to practice in Arizona. But if you combine the two and you do both medical school and residency in Arizona, we retain 75% of those. So that's a significant incentive for us to take these increased numbers of medical students and ensure that we can have them stay here for their residency program. We'll have a much better chance of improving our workforce needs if we can do that. Otherwise, we just continue to leak our students and our graduates into other states. So what are some predictors for keeping our students here? And there are lots of them. There's literature around this, but I just came up with a few that I've actually anecdotally seen to be the case. Obviously, we know from the last slide that if you do both your medical school and residency here, you have a better chance of keeping the students here practicing. If we can have more Arizona residents into our medical schools and our residencies, they generally like to stay in the state that they're from. The biggest driving factor for everybody is personal factors. If you have a spouse who's from another state, or you grew up in the snow and you want to go someplace sunny, those kinds of things, chances for their kids, the personal factors often drive where the physician often wants to practice. This is particularly an issue for rural. We've gotten lots of programs that have enticed our graduates to go into rural communities, training there, great experience. They love the rotations in the rural communities, but it's frequently the spouse who says, I just don't want to live in the rural community, or I want my kids to go to XYZ school. And so we have to begin addressing those kinds of factors as well. Most of our graduates now, as you might guess, are employed. So that was not the case when I graduated. I set up my own solo practice originally, but that is rarely the case these days. So our students and our graduates from our residency programs are really looking for an employment of some sort, a salary of some sort. And many of our graduates do want to have academic careers or have research opportunities. So they're going to go only to go to places that they have those opportunities and keep them there. And then salary is definitely still an issue. And can they progress in their career, for example, into leadership positions in, say, clinic management and that type of thing?
All right. So really, as we look forward and thinking about what we need to touch on, we would love any guidance from all of you, but we picked out a few things that we really think are important as we continue on this path. First off being the clinical training sites and what the capacity is. And we know this is a solvable issue for some of these spots, and we think that this really is probably the most important thing to look at, right? If we're going to have new medical students, we want to make sure that they're able to train here. So that's a really important step that we'll be looking at closely. Obviously, the financial needs, right? Facilities, faculties, student services, that you have all those available. The accreditation requirements we handed you a graph that shows kind of the long process for accreditation. For an MD school, it's about a 5 to 6 year process. Starts with being candidate status, then you have to, and you cannot recruit a student until you get your preliminary accreditation. So you have to achieve preliminary accreditation before you can even have a student apply to your school. Then you've got provisional accreditation, which comes when your first students are about in their second year, and then full accreditation, which comes in your 4th year. So it's really a long process, and I can tell you we have the battle scars from that. And Dr. Gabriel's got the battle scars. But right now they're working on their DCI, which is the data collection instrument, which is about 900 pages of documents. Everything about the curriculum, but down to the size of the lockers that the students have. LCME
To meet the minimum requirement.
Yes, and the LCME looks at everything from the viewpoint of the student. So they are looking at, does the student have everything that they need to be successful in this role? So they're really looking at it that way. They're not so worried about the universities or the administrators or the staff. They're worried about those students, and they're really looking at that. And when we talk about GME, it's really thinking about those medical students that we're producing here. And so we talked about what those numbers would look like if all of those came into fruition. And we're ranked about 39th for the number of medical students per capita here. If all of those spots came into fruition, we'd be ranked number 2. We'd be right behind West Virginia, which is a much smaller state, has 2 medical schools. But that gives you a little bit of perspective on where we are with all of that. And of course, we want to look at the applicant pool, right? We're really excited because all 3 universities are working on a lot of pipeline issues and really helping to have Arizona students be prepared for medical school and to look into those underserved and rural areas and to pull students from there. And that's really exciting. That's what we're going to need to really be able to help solve this problem. And of course, all 3 universities are really looking at primary care, rural and underserved needs. And that's really what is important not only to our state, but as we look forward to what we're doing.
So Judy and I have established a work product to try to address some of these, to try to get more information, to serve as a resource for you so that you know the different kinds of questions that need to be asked and need to be addressed in order to meet the challenge to deliver the workforce that we need for the state. So we're in the process over the next couple of months of setting up meetings to get more data for you on these areas.
Perfect. Thank you. Are there questions or comments from the board?
Regent Penman?
Thank you, Regent Manson. Thanks very much to both of you. We're happy to have you. I'm personally happy to have you and appreciate the insights that you've provided today. As you probably know, the three presidents in this board have really announced a very major goal if you're talking about moving to second in the country in terms of number of medical students per population. So it's a huge undertaking. As you noted, it's going to demand enormous resources to get there. One of the things that I'd be interested in as you look at these issues is how we can build the kind of support from our state, from the Arizona Medical Association, from our physicians in general, and obviously from our legislators and others who will influence the extent to which we can really pull together these resources. I'd like to think that the Arizona Medical Association is deeply enthusiastic about what we're trying to do here. That, I mean, at least physicians I talk to ask me questions about it, which I always like because they're asking me questions that I think indicates they have a keen interest in this. So how can you all help us build a sense of momentum that really will engage important constituencies in supporting what we need to really accomplish this very huge goal?
I'll take a first shot.
All right.
I think what you described is absolutely critical. Totally agree with you. And what we need to do is to begin building coalitions. And they need to be very, very broad. The state, the physicians in the community, even insurance companies, business leaders, many foundations. This is going to have to be the whole state coming together to achieve this goal. It is a lofty goal. But at the end of the day, not only will we have a better workforce, but we're going to have really even a different level of healthcare delivery in this state. And I'm not saying, being a doctor practicing here, that the current state is bad healthcare. I'm just saying that we, in order to have better access and do the kinds of things we need to do, and even ramp up our research portfolio here, there's a lot to be done, but it's not going to be on the back of any one entity or one person, one university. It's going to have to be everybody pulling the load.
And I think there are some really important aspects to that when we think about this and as we talk about it, right? Because the one thing that we all know is this is very relatable, because we all know that sometimes it's really hard to see a physician, right? That it's challenging. And so I think that is the first step, that it's relatable even to legislators and to business folks, right? They're experience the same things that all of us do. And then I think the other piece of that is economic development, right? We know that a medical school especially has a tremendous economic impact. So from the research, from the number of students, from the number of faculty, from the number of clinics that are going to be created, right? There's an economic impact to every piece of that. And there's also the piece of innovation, right? So what's being proposed is very innovative for all of these programs, and that puts us on the map. And if we think about what attracts a company to come to a place, one of it is that they have good access to good care, right? We know that that weighs on the mind of leaders when they come in. So I think all of those pieces come into play a little bit when we want to take this forward to how we find it. But to your point about resources, it's absolutely critical, right, that we have the resources to do this well.
Yeah, if I could follow up. First, relative to the potential being number two, that assumes that everybody else is static.
Correct.
So, got to be mindful of that.
Yes.
Second, I wonder, while the 75% retention rate is pretty good, take it over many, many other states, every single physician that we train at great taxpayer expense who leaves is a cost that we should try and avoid. Can we, or do we use, since you've described that there are predictive things that we know are more likely for an applicant to make a long-term commitment to Arizona, are we allowed, or do we use those predictive measures in selection of our medical students?
We need to gather a little bit more information on admissions data. I've just started this last week getting some of that data. But traditionally, in the past, yes, we have ramped up the number of Arizona residents that we get in the pipeline, knowing that that's one of the factors that will predict hopefully retention. So that alone is achieved. But I think you're right, we do have to look at different models. The curriculum actually does draw particular students to a school. So if we have now 3, 4 different models of medical schools, we have a better chance of having interest from a broader segment of Arizona students coming in, university students coming in. So if we have a medical school really focused on engineering and medicine, that's a draw to a certain number of students. If we have one looking at rural, underserved, that's a draw to a certain number of students. And the 2 U of A schools have their own differentiations that draw a particular kind of student to those schools. So that breadth will be an additive value, I think, to us. The other factors I will discover when I talk to some of the admissions deans over the next month or so.
Look, I appreciate that, and thank you, Madam Chair, but just follow up. I mean, it will take years for us to get to this kind of scale that we're talking about. So the fastest grab for more physicians quickly is to go after the retention rate. So, get that up to 80, 85, 90%. So thank you for focusing on that.
Yeah, I appreciate that. I really am kind of running out of time because we have updates from both NAU and ASU on the progress of their schools. I do want to make a couple of comments before we finish. And first of all, thank you both very, very much. This is very helpful. To me, it seems like the GME issue is the biggest stumbling block to any sort of success we have here. We may be able to put more students through, but if we can't keep them here for their GME or bring people in for their GME, I don't want to say we've wasted our efforts, but if the goal is to get more physicians in Arizona, we certainly have not optimized that opportunity. So if you all can, in your work going forward, kind of focus on opportunities for us to be successful, paths we might follow to get the expansion of that GME, I think that will be really helpful. The other thing was the retention rate, the rural. Do we have the opportunity to, I mean, I know vet schools in other states have essentially said, hey, if you go to school here, you do your residency, or you do your residency and stay here, we will forgive a portion of your debt, or we will, there are incentives to keep people in state. Same thing with rural. So if we accept you to a medical school that is geared towards rural care, if you stay and work in a rural population for the next 5 years, what's the, is there a refund? Is there a incentive that helps you make that choice? Or are we simply going to have to, as Regent Duvall said, recruit people who truly have that focus, no matter what the monetary implications of staying rural or the family implications of staying rural, that they understand those when they come in. So those would be 2 pieces of kind of forward-looking research that would be really helpful, I think. So thank you very much. I look forward to next conversations.
We already have that for both of our medical
Right.
schools and the vet school.
Yep.
If you come back and serve, no matter where you do your residency, you go for free.
Right. So I think those are things that we just, but if we can't, it's hard to get people to come back when they've spent their 3 years in the emergency room in Miami, and they want to deal with gunshot wounds. How do you get them back to Arizona?
Because they owe us the tuition for their medical school.
That's the one.
It's a good hook.
Yeah. But there's a financial implication to that as well. So you have to, figure out how that works. We are going to have 2 10-minute updates, one from NAU and one from ASU, regarding the progress on establishing their upcoming new medical schools. And I'm going to start with Dr. Shireen Gabriel from ASU, and then we'll move to Provost Karen Pugliese. Yes?
I'm going to take 30 seconds of Dr. Gabriel's time.
Did you ask her?
No.
No? Didn't.
It's just a reminder to the regents that, yes, we have a medical school that's being planned and being initiated, but it's in the context of an entire strategy that we call ASU Health. One element of that strategy is rapid expansion of nursing production including clinical nurses, including nurses that could run clinics and go to the front line of dealing with people as nurse practitioners in Arizona. So the totality of what we're doing is anything we're thinking about is anything other than the regular way to do this, because we've already seen that that's a slow process. So we're looking at a different design for the medical school, a different kind of doctor that will be produced, a different kind of nurse that will be produced, a different kind of public health technologist that will be produced, because there are other ways that you could get health outcomes and reduce the flow into these systems. And so, yes, we're going to produce doctors. They're going to be different kinds of doctors by design, but we're not approaching this as an isolated thing. Dr. Gabriel.
Thank you. And I just have to say, the stolen 30 seconds was basically my first 30 seconds. So, but I couldn't have said it that eloquently. But I'll just start by underscoring everything my two colleagues here, Dr. Chadwick and Ms. Burnaz, said, and highlighting the challenges that not only we all face here, but are faced really nationally. So, and I love the notion of building coalitions, because if at the end of the day we're competing, that's not what we want for Arizona. So yeah, I'll shorten my little intro here, but I was really going to say the same thing, is to remind everyone here that our medical school is nestled within this larger ASU Health initiative that includes, of course, the medical school, but the School of Public Health, and substantial growth in nursing, substantial growth in biomedical research, a number of community-facing initiatives in health literacy, with KAET and with the public school, with the school systems, and even considering a network of clinics in the region. And so we really hope that this integrated suite of initiatives will together move the needle on health outcomes. And I'll just mention a couple of things in terms of our specific progress. Actually, you alluded to the fact that our medical school is not going to be traditional. It's going to have embedded within it engineering, AI, data science, and also a strong thread of humanities. One of the central tenets of ASU is the fusion of disciplines, and we are fusing all of those disciplines to create a unique new curriculum that will do all of those things, but also focus on our community. With respect to specific progress, we are officially a new medical school applicant on the LCME website. That went in the fall of 2023, the accreditation body for medical schools. We are, as was mentioned, working on the data collection instrument for preliminary accreditation. We hope to be able to submit that spring or summer of this year. And if that happens some months later, there's a site visit by LCME, perhaps late in 2024, depending on their schedule, which will lead to preliminary accreditation next year. And again, if all goes well, admitting students in 2026. And that will mean provisional accreditation in 28, and the inaugural class graduating in 2030, which is when final accreditation happens. So it is a very long process, but we're well on our way. We've assembled what I believe is a visionary leadership team that aligns with this novel vision, creating this curriculum, medical school curriculum that
Shereen,
has.
just mention who we have hired, who you
Yep.
already brought here, okay?
Yep,
It's next on our list.
It's next on my list.
Yes, thank you.
yeah. At least a few of them. I don't know if I've got everybody you're mentioning. We've launched a national search for the inaugural dean. Dr. Randy Bird, who's an experienced academic executive. He was a provost for many years at LIJ. He created and led the accreditation of a number of schools, so he's leading that entire effort. Archana Pradhan is a senior medical education advisor. She's associate dean for medical education at Rutgers Robert Wood Johnson Medical School. I had the pleasure of working with her in the past, and she's joining us. Melanie Dean is Senior Director of LCME Accreditation. She has guided medical schools through, yes, one that we know very well, through brand new medical schools through LCME accreditation and follow-up accreditation and site visits, so she knows the ropes extremely well. Jordan Colston is Assistant Dean for Clinical Curriculum. He's an experienced clinical medical educator, leader in simulation and clinical skills education, and we're also happy to have brought on Rebecca Fisher as Director of Anatomy. She's got incredible experience, not only in anatomy, the way we learned anatomy, but virtual anatomy, and she's one of the foremost researchers in the country regarding virtual anatomy simulation. And we're working with her as well as with folks at Case Western to really bring that, that program forward. We're also collaborating heavily internally, which as we have to, so with our academic enterprise, under the leadership of our provost, Nancy Gonzalez, to design this dynamic MD degree that, as I mentioned, fuses a number of disciplines together. We've had 12 interdisciplinary design teams working for many months now with over 70 faculty and staff. I think we're logged in more than 100 design sessions so far, and a number of consultations, external consultations with model medical schools and experts externally. John Mahoney, who again you folks know is physician engineer himself, has been one of our primary advisors right from the beginning. He's a medical education expert, and just to list some of the schools where we've made visits and are working with TAMU NMed, which is another engineering medical school, Texas A&M. UIUC Carl, they're known as the first engineering medical school in the country, and they have a big focus on innovation, as we will. I mentioned Case Western Reserve. They're really the foremost leaders when it comes to anatomy, virtual anatomy and simulation innovation, and we're working with them to adopt the best in class, but also to move beyond that and create sort of the next leap there. Harvard and Duke, just looking at their medical curriculum design, which is outstanding, and we're planning, we haven't done this yet, a visit out to Stanford. We're also making progress with respect to our clinical affiliations. You know, you can't have a medical school without clinical affiliations, and as President Crow has said at so many of these meetings, we are approaching it as a hub and spokes model, so very non-exclusive. We are affiliating in various ways with every single system in the region. You know, Barrow, and I'll just mention Barrow and Phoenix Children, everybody else as well, but Barrow and Phoenix Children have already agreed to be our educators for neurology and peds respectively, and we have a number of others that have agreed to rotations and electives and even planned fellowships and working together to strengthen their GME programs. In partnership with our KE, our knowledge enterprise, our research leadership under Dr. Morton's leadership, building a portfolio of industry leaders to jointly design, build, and deploy transformative health solutions. So, you know, innovation and engineering and AI is part and parcel of this education, and we're teaching them not only to see patients on day one, but to begin thinking differently about health solutions on day one. And we want to use these industry leaders to help us think through what that might look like. And so we're beginning to do that. Over 100 connections made with these prospective industry leaders, and 25 of those have moved to the sort of the due diligence and substantive follow-up stages. So I'll maybe just stop there and just, yeah.
Development officer.
Oh, yes, I forgot to mention that. I knew I'd forget something. We recently hired a development officer, that's Carly Neary, who's dedicated to advancing fundraising for not only the medical school, but ASU Health in general.
She was the chief health fundraiser for Oxford University.
For Oxford for a number of years, but prior to that, she was right here in Arizona, actually, at ASU. So.
Perfect. Thank you. Any quick questions for ASU? Seems like great progress in a very short period of time, so thank you very much. We look forward to the next steps in this. Provost Pugliese.
Good afternoon, Regent Manson, Regents. It's my pleasure to only give some introductory remarks today. As you know, the NAU Health Initiative is a comprehensive strategy to expand capacity in a suite of health professions and behavioral health programs that we offer and create opportunities for those professionals to contribute to better health outcomes throughout communities in Arizona. NAU Health builds on our very strong portfolio of programs in nursing, allied health, health professions, and behavioral health, buttressed by partnerships throughout the state, and all are focused on preparing professionals for rural and underserved community practice. In the next phase of our initiative, we are looking to extend into medical education. We are in a far earlier stage in our long journey. We have brought on a new leader to take the lead with the development of our medical school, Dr. Julie Baldwin, who is a Regents professor and director of our Center for Health Equity Research, joined us this January as the NARBA Institute Vice President for NAU Health. And I'm pleased to introduce you to Julie and turn it over to her to talk about where we are with our medical school project.
Julie, you on mute.
There we go. Can you hear me okay now?
Yep.
Thank you so much for this opportunity. I'm sorry that I can't be with you there in person, but I really appreciate this chance to visit with you on Zoom. So as many of you know, we view our new College of Medicine as being distinctive from the other colleges of medicine in the state and region, as it will be designed to broaden participation, accelerate graduation and timeline to practice, and hopefully maximize impact on health outcomes with a reduction in health disparities in Arizona's most underserved communities. I'd like to just share a little bit about our vision. We would like for this program to be accelerated if possible. So potentially a 3+3 program, 3 years of undergrad, 3 years of the medical degree. We want it to be affordable. We want to be able to graduate students with lower debt, perhaps offering a tuition-free or tuition-reduced program, as was mentioned earlier, with commitments to return back to the state to practice. We also are teaching focused, so we're building on NAU's assets in health equity, population health, biomedical research, and indigenous knowledge. We want it to be integrative, so incorporating behavioral health, community population health, social determinants of health, and we also want it to be culturally informed, so especially indigenous and Hispanic health traditions and practices. We also see it being very community-based, as was mentioned earlier by Jackie and Judy, starting clerkships and clinical training early in the program, and expansion of our residency programs through our partnerships. I do want to note that we will not be standing up our own healthcare operations, so of course it's very critical that we partner with other health systems around the state. And then also preparation for practice in real world environments to produce both resilient and trusted practitioners for our local communities. So in terms of our progress to date and some of our plans ahead, as Karen said, we're earlier in our process, but we are reconnecting with the existing medical education advisory committee members, and we've been inviting some new members, both locally and nationally, to serve on the committee. Upon recommendations from the advisory committee, we're working with consultants now, Stacy Chang and Natalie Privet, who have a consulting firm called New Origin Studio. They were involved in helping to develop the University of Texas at Austin Medical School and the entire healthcare system there. They will be facilitating a design summit for us that's planned for April 3rd. And the first phase of this work will bring local and statewide stakeholders together to discuss the context, support, and partnerships that will allow us to achieve our goals. In the second phase, we will use the learnings from this design summit to then enable our national members of the committee to provide advice and recommendations that will optimize our particular circumstances for NAU. And then the third phase will develop the foundation for a system strategy for NAU Health that builds systems of stakeholders, their priorities, and the exchanges that need to happen between them, for us to be successful. Alongside our consultants, our NAU team is planning to complement this work by holding community listening sessions with groups of local providers, health department and health system leaders, and tribal leaders this spring and early this summer. We're also in the process of reviewing best practices and innovative models for medical education, and we plan to visit with a few medical schools that have specifically accelerated rural and indigenous tracks. We also hope to start conversations soon with national experts on accreditation requirements and the steps. And then finally, we will likely be conducting a local regional needs assessment this summer that will complement the work that ABOR has already done and will help inform our planning. And I might just mention at the end, we're very thrilled to have both Judy and Jackie on too as consultants. We're looking forward to working with them. Thanks so much.
Thank you very much. Any comments or questions? Yes.
Thank you. Thank you, Chair Manson. Dr. Baldwin, Provost Pugliese, thank you for the update and on the Arizona Healthy Tomorrow. Since you're focusing on the rural and underserved community and we have the same problem, what would you do different? Because this is heavy on what you are going to move forward. Any comment on how can you address or differential on how creative can we retain doctors in those community? Because that's, I come from a rural community, so I'm now in, in a different space, but that has been always in general, nobody wants to stay there.
Do you want to address that, Karen? I can't see you right now, so I don't know.
I know.
Okay.
Go ahead, and I'll jump in behind you. Why
Okay.
don't you go ahead?
Well, I think one of the strengths that we have at NAU is our community relationships, and with community-based organizations, with our tribal partners, et cetera. And we've already started to engage in a number of conversations with tribal leaders, for example, Indian Health Service. I can see an important partnership with the VA system as well, and working at the grassroots level with community leaders too. And I think that already through our undergraduate programs, through some of our other programs that Karen might want to speak to, we have a large number of students expressing interest from underserved communities to come to NAU, to get engaged in different types of academic programs, and already interest in the medical schools as well. So I think that networking and that process of community engagement is going to be very important.
Thank you.
Thank you.
And then thank you, Julie. And I guess what I would add is building on the remarks that were made earlier about some of the factors that are important for retention of practitioners in the state of Arizona. And we hope to essentially leverage those in a way that would be advantageous for producing primary care providers that would be likely to stay in Arizona, especially in rural communities. Among those things is the way in which we recruit and select students to be in the program in the first place. And we have been thinking already about a more holistic approach to doing that would select students that have maybe a particular interest or connection to some of these underserved communities, that have an orientation to service. And then in addition to that, building into the curriculum very specific kinds of preparation for that distinctive arena of practice, which we've learned can be a very challenging arena in which to practice medicine and primary care. And we hope to have design into our program the kinds of integrated clerkship experiences that will prepare them very well, and then they will be more likely to be resilient, because I understand it's not just getting them in the first place, of course, it's retaining them in that arena of practice. The other thing is that affordability is an important component of this, as has been mentioned. One of the levers that is valuable, as is done at University of Arizona, is having some way in which there's not a financial burden to persist in maybe what might not be the most lucrative area of practice. And so we're certainly hoping to have a program that is affordable, not as expensive, partly because of its accelerated and partnership design, and then hopefully we'll be able to secure the resources to provide the kind of funding support for the students that they will not graduate with debt that will drive them to a more lucrative specialization in their residency and fellowship phase.
Mm-hmm. Thank you.
Thank you very much. I really appreciate this. The updates on the two programs have been well received, I think, and we're very interested in how they're moving forward. As far as NAU specifically, before we leave today, is that this education is not inexpensive to provide. And I think one of the factors, or perhaps, I don't want to say the factor, but fundamentally, this can't be successful without some significant funding behind it. And so I would encourage the university to keep us kind of informed on progress and opportunities in that arena, because that really, if that is not available, I don't know how we do this. Yeah. Okay. So
Agreed.
any other questions from the board or comments from the board? Perfect. Thank you all very much. We appreciate the input today. And this is the conclusion of the Strategic Initiatives and Planning Committee. And I thank you all for your participation. We are adjourned.